because it's been a very long day. This will be a lively session because I've had a chance to speak to all of the panelists, and none of them are the kind of people to go along with ideas they don't agree with. Is that a fair statement? I think. So I'll get them all to introduce themselves in just a moment. Throughout the session, we're going to ask you, if you have something to say, to put your hand up, and we'll try to get questions or comments in as we go, rather than leaving that to the end. So let me ask our panel to introduce themselves. So Jay, do you want to?
Hi, I am Sujay Santra, founder and CEO of iCure. iCure is a for-profit social enterprise which is providing affordable, accessible primary healthcare using technology. So we scale our solution in 3 ways. One is own, wherein we set up our clinics; operate, wherein we work with partners such as corporates; and enable, wherein we work with governments in partnership with multilateral agencies. Thank you.
Hi, my name is Tu Do. I'm with Gilead Sciences. We're a pharmaceutical company primarily specializing in HIV, hepatitis, and other virology and neglected tropical diseases. The group I specifically belong to is called Global Patient Solutions. So we're really focused on creating access to medicines for those therapeutic areas, specifically in low, middle income countries, and specifically with populations that face huge health disparities. So we're really guided by, our social impact and the ability of where we can make a difference the fastest. And that's, again, why we focus on populations that have disparities in terms of health outcomes for HIV, hepatitis, and other neglected tropical diseases.
Great. Sue?
Afternoon, everybody. I'm Sue Hussain. I'm the Network General Manager for Unjani Clinics. We are a non-profit organization based in South Africa, and we look at implementing primary healthcare clinics in communities across the country, which are nurse-led and ultimately nurse-owned. So the idea or the concept behind Unjani Clinics is to give quality, affordable access at a private sector entry point into the communities that the nurses come from.
And Wanjiru.
Good evening, everyone. My name is Wanjiru Munene, Senior Advisor, Market Shaping and Development for InSupply Health. InSupply Health is a startup that is an affiliate of John Snow Inc. We are essentially an advisory and consulting firm in terms of supply chain. We mainly work with governments, and we implement for donor partners like USAID, Bill and Melinda Gates, and GCC. Thank you.
Lovely, thank you. And you know from the theme of our session that what we're going to talk about is inclusion as well as equity. So often we hear about health equity, and usually what people mean by that is the health of the poorest and the most vulnerable. But what you've heard speakers throughout yesterday and today talk about is inclusive economic development. So we want to get that idea of both equity and inclusion into some of the innovations we're talking about. And you will have noticed from all of the speakers that they're all kind of on the edge of the public and the private sector. So they're at the interface of the public and the private sector. And that's another part of what we consciously wanted to do today, which is to talk about how we build these collaborative and maybe unusual systems with a bit of tension in them. Which brings me to the first of our broad discussion themes, which is how governments can support the use of technology to improve access to care, and what governments can do better. And so we have a couple of examples from our panelists. I have too much technology here. But we have a couple of examples from our panelists of where governments are doing well, right? So Sue, maybe I'll start with you. Clearly South Africa has an enormous HIV problem, most of it managed in the public sector, but you're managing some of it in the private sector alongside government, right?
Yes. So because the clinics are based in the communities where the patients are, what we have introduced and what we're trying to promote is more active HIV testing, initiation, and then follow-up. So the link is now for our nurses and our field workers to then use that data, that manual data, and feed into the government system, the REDCap system, so that we can continue care for that patient and we don't lose the patient record, which is important.
And the government said, yes, you can feed into our system. Yes, you as a private provider can be integrated, but
they would still own the data. So it's a matter of us feeding our information into them, whether it's manual registers or weekly meetings with the, I would say, the local clinics more than a national level, because the local clinics would then support the ARV dispensing as well as laboratory testing for those patients who can't afford it in the private sector. And there are, I would say, a fair amount of patients who can afford to pay for their treatment as well as their testing.
And do so because it's convenient and it fits their lifestyle.
It does.
So, interesting example of government being flexible in a super sensitive area. Wanjiru, we have another example from Kenya of government adapting to a model that isn't part of the public sector system, right?
Yeah, thank you. So basically, I'd like to give an example in terms of supply chain, which is mainly the area where we work. We basically support governments in terms of setting up supply chains that could support in terms of healthcare outcomes and health impact. So we recently just deployed something we call the C-Stock approach, which is basically a community health last mile delivery system, where healthcare facilities in the most vulnerable communities, and especially in the remote areas, are able to trust community health workers. These are people who were not trained as healthcare workers, but some of the activities are delegated to them because there's a system where the healthcare workers can monitor and have visibility of what is happening on the ground. A good example is, for example, in the pandemic time, right? There was a limitation in terms of what the numbers that the healthcare workers could attend to. And some of the diseases or some of the cases or issues we see in the communities are very simple, but at the same time are very, could cause morbidity issues and mortality issues. So healthcare workers are given certain commodities, simple commodities like oral rehydration salts in terms of in areas where we have breakouts like cholera, diarrhea. They can dispense malaria nets and treatment for malaria nets themselves. And they can offload some of the burden for the healthcare workers to deal with more critical issues happening in the healthcare facility, and especially in the pandemic time.
So the healthcare workers delegating to someone in the community control of those supplies of malaria medicine, for example?
Yes, so over and above offloading the workload, you have also the issue of accountability and efficiency in the system, because you have technology that the government has actually agreed to integrate with their systems, because the healthcare worker in the healthcare facility can see what the community health worker is dispensing, and they can also see how much stock they have on hand. They can see when they're running out of stock so that they can also ask for more stocks from the higher level, right? Because it's all like a system supply chain.
We've got an example from Rwanda too. Where's Aristide? There. Aristide, could we get a microphone to Aristide? Because we have an example of the same kind of adaptive approach to regulation, just over there, that took place in Rwanda. Aristide, well, introduce yourself briefly and tell us about it.
Yeah, thank you. My name is Aristide Karasira. I'm the CEO and co-founder of HarakaMed. So HarakaMed is a digital platform where we democratize access to healthcare products through technology. So one of our products today is an online pharmacy. That's a very new concept in Rwanda, where people could buy their medication online and have access to healthcare professionals through technology. So I will use our own example in HarakaMed to tell you how we got to register at the FDA, the regulating body here in Rwanda. So it was quite a new idea that we took to the FDA to have an online pharmacy in Rwanda. And from their side, they told us they didn't have any regulation in place like that. So, but again, they didn't just chase us away or something. They appointed a team to work with us, established the guidelines together, and hear us out. So the bottom line here is governments and regulation bodies should have this attitude, this positive attitude of hearing out new ideas, innovations, so that like today we have a license that was processed in about 6 months of time. So that attitude led to that, and now we have more than one online pharmacy in Rwanda. So that's my contribution to
Thank you, Aristide. I mean, so for the rest of us, we should all feel pretty awed by that. Government went from, we have no framework in place, to we're ready to issue a license in 6 months. And I come from another small country where sadly I can't imagine us doing that, but more power to Rwanda. So too, the interesting thing Aristide said, Wanjiru said, pandemic, some of this flexibility is undoubtedly pandemic induced, some of it not. The ICT minister set out that amazing 5-year framework and her commitment to startups. But a lot of this is pandemic induced. What's the risk that as the pandemic becomes the normal, this appetite for collaboration and innovation disappears?
Thanks for the question. And I think it's a really important point. You know, in a post-COVID world or still in a COVID world, what's clear to everyone is that when borders closed, we really had to look inward and understand, you know, the fragility of weak health systems. But within that kind of crisis, so much innovation is happening. These are 3 examples that were there before the pandemic, but certainly closed and served a really important gap during and beyond. And so I think what's really important to encourage is that these don't get rolled back as we adapt to new normals, we feel the urgency less, but that we take learnings from them and learnings that a mixed system where private sector, something in between, not-for-profit, you know, innovations that serve all aspects of the income pyramid, those are what's gonna keep, you know, fragile health systems developing, building, and progressing. So what we really hope to see, especially as Gilead, you know, is trying to provide access to medicines in low-income environments, is a really healthy mix of those innovations. And I know, you know, we hear these phrases like leapfrogging, but some of the examples, and especially, you know, the pandemic and what we've heard across this conference in the last 2 days, is that when that governance and when that buy-in and that, you know, political will is really invested into local innovations, that it can do wonders. And so again, really just supportive of the idea that in a post-pandemic world, we really center the ability to learn from this mixed ecosystem and continue to, you know, encourage it under the stewardship of the public sector, so that it is really tackling that equity question and that inclusion question, you know, not things just built for the poorest and not things that are just available to the high income, but essentially, you know, being able to come together so that we're on a cohesive and comprehensive road to essentially universal health coverage, which I know everyone in this room is invested in.
As an American, as a European, I think we both get the feeling we're being leapfrogged over. And it's good. It's great. Yeah, it's good. We welcome it. There's a couple of minutes. Is there anybody who wants to jump in from the audience? A couple of minutes before? No, good. Okay, let's move on to our second question. So our second broad question, as you know from the agenda, is about matching healthcare aspirations. So matching the stuff we all want to get done with the need for data protection and for privacy. And how we adapt to regulations to address privacy and equity and transparency and safety. I have to say, I was speaking to the head of the Robert Koch Institute, one of the regulatory institutes in Germany, and he highlighted this as the biggest barrier. He said it's really, it's great that we in Germany are so focused on privacy, but it was one of the biggest barriers, he thought, to the adoption of healthcare innovation, because it rests so much on data sharing. So our panel have got some experience of how to deal with this. Sujay, let me start with you, if I may, because we've heard a lot about India's commitment to open data, to this model of 4 or 5 companies not owning all of our data. And tell us about how that's been applied in healthcare.
Yeah, thanks, Mark, for that. And in the morning, we have seen Amitabh Kant also sharing that how India is actually looking at open data, infrastructure and the architecture. So just to give a quick example for us, India, we all have an Aadhaar or a unique ID, and now India is building up the NDHM, or National Digital Health Mission. And I'm also part of the National Core Committee of CII, Government of India, wherein we are discussing that how you would be able to build that, and it's not as easy as it may sound, because here you have to deal with patient patient with a health worker at a village level, then at a block level, state level, and at the country level. And then maybe, let's say, if you want to share a diabetologist some data, maybe you do not want to share a gynecological data as well. So there are a lot of data privacy as well as part of that. And for us, in order to have the interoperability, in order to have the strengthening of that, because let's say when we started the work in the middle of the pandemic for Nagaland, and the health minister of Nagaland was extremely nervous because they were not having any such kind of data across 11 provinces, that which of the states or which of the locations had problems related to the NCD areas like hypertension, cardiac ailments, which are the comorbidities during that period. But here, what we have been able to do and map in terms of how iCure enterprise and how we have been able to collectively form that. The biggest example of the data interoperability is the vaccines, because here we have seen that, like in my case, I have taken the first vaccine from a public government and the second two from the private, but my vaccine card has all the three in one place. So if there is a will, you would be definitely able to integrate all of that. And just to give one quick quote, when we started iCure in India, a lot of people said that, why are you in this space, you in primary healthcare? That's a state subject. But post-pandemic, I am sure that nobody would dare to ask that question, because I think the future of healthcare needs involvement of the public and the private, and need to introduce architecture which could be adopted by one and all.
But it is that question, isn't it, of how we get data protected but still accessible enough to allow you to the choice. I'll have one vaccine here, one vaccine there.
Absolutely. I think the whole architecture has to be understood in a way wherein the standardization has to be there, and how you would be able to share the data in a meaningful way. And unfortunately, within the public healthcare system, we have not invested enough on that piece. If I give the example of financial data, when I'm in New York, I'm pulling my money from the ATM in New York. I'm pulling the money from my Indian bank. But if I am getting sick, if I need to go to a doctor, I cannot pull the data from an Indian data system. So why it is not possible? Nobody has actually thought around that. But if we are able to have certain standard architectures in place, so even in financials, we have the privacy in place, because the ATM in these things may not be able to share the data in a certain way. So there are certain standards, architectures, and if we are able to make those architectures in place, I'm sure we can definitely do that. And as part of the data privacy, which we are working with Microsoft on confidential cloud computing and certain technologies, it's only when the patient is able to give the certain authentications, you would be able to share the data. So there are certain levels which are being played, but it will take some time, but that has to happen.
Willeen, who's from another of the online pharmacies. There you are. Can we get a microphone over there? So, Willeen, I mean, obviously, pharmacies are potentially delivering sensitive medicines. They've got hold of sensitive data. Tell me how you make sure that doesn't get into the wrong hands.
Okay, as said, my name is Willeen Kirezi. I'm the current managing director at .pharma, which is a digital platform that helps patients to get product delivered to their homes. And about that question, an example for how .pharma does that, we actually believe in patients being the center of the business you're doing, and ensuring that if they confide in us about their patient's information, we have to make sure that confidentiality and privacy is at maximum. So, for example, we can send or deliver anonymous packages where the person that is delivering those packages doesn't know what's inside, if it's a certain scaly product, if it's some product that can cause stigma, they don't know. And we don't put names and location. A patient has the right to say, you can leave it here, I will come and take it. So we just make sure that what the patient wishes is what is being done, to ensure that that privacy and confidentiality is highly maximized. Thank you.
Thank you. And I guess we all think about HIV and we think about diseases like that, but I was really struck. I was in Cameroon and talking to a man who'd been diagnosed with hypertension. And he said, if my family found out, they'd assume I was going to die. It would panic my family. I can't. And if my employer found out, I'd be fired immediately. And so it's up to the patient to define what's sensitive and what's not, what's something that may not seem it to us. I want to try, anybody got anything to add? If not, I want to try a little exercise before we go on to question 3. Okay, among all of you in the room here, I'm going to ask you to pick one of 3 positions. So position 1 is, I'm prepared to put up with a lot of inconvenience, reduced choice, but I want my data protected completely. Position 2 is, I want some choice, I want some ability to access my data when I'm traveling to New York and I have a health problem, but I still want safeguards in place. And option 3 is, you know, provided basic safeguards are in place, there are passwords, there's some protection, I put convenience and I put choice as my highest priority. So are the three options clear? Okay, show of hands. Option 1, maximum privacy, minimum convenience. How many of you would go for option 1? Wow. Okay, option 2, kind of a blend. Privacy, convenience, trade-off. What does that look like? About 40% of the room? Okay, and option 3, I want basic safeguards in place, I want a password, I want
Mark,
another 40%.
a comment.
Yes, really fascinating, please.
Why the binary?
Why the binary? Yeah. No, I agree, it doesn't have to be a choice. In a perfect world, it doesn't have to be a choice. You're right, Shu. But it's really interesting to see that, because I think we often overestimate privacy concerns. So it's just interesting to see. Thank you for indulging me taking part in that exercise. So any thoughts from the audience on this? If not, we'll move on to question 3.
Just a passing thought. I mean, if privacy was such a concern, Facebook and Google would not have been the same as that, as simple as that.
Exactly.
Everybody knows Facebook steals data or they're trying to do something, but still everybody is on Facebook in a way.
And whenever people ask me about privacy, I ask them how often they use incognito mode in their browser. And they usually just look at me blankly. Because Google is also tracking through cookies whatever you're looking at on other sites. Yeah. Shall we move on to question 3? Question 3 is possibly our meatiest of questions, which is how the changes that have taken place in the pandemic, or been accelerated, because you're right too, a lot of them were in place before, but have been really accelerated by the pandemic. How can these innovations, many of which are technological, be leveraged or scaled to improve equitable and inclusive access? So let me spend a little bit of time, if I may, and I come to you first too, talking about what we mean by equitable and inclusive. Because we don't mean, do we, the CEO goes to the same hospital as her cleaner. That's not what we mean.
Yeah, no, it's a great question and a great kind of unpacking that I think is important. You know, you started this off that potentially, you know, the perception of equity is just focus on Q1 and Q2, the lowest income quintiles, and if you build something for them, you've achieved equity. Certainly, you know, the definitions of health equity is the removal of barriers that, you know, are social determinants of health so that everyone has access to health and wellness. You know, the barriers often, most commonly impact Q1 and Q2. But as we think about, you know, the path to universal health coverage, equity has to be inclusive. And that really means getting solidarity and buy-in and creating a system that is able to serve everyone. And it's not one size fits all. Certainly, we know that. That's never going to work. But it's that everyone has a size that's still, you know, stewarded under a common system. Because the hope is that, you know, people's position in society, especially Q1 and Q2, is not stagnant. It's not fixed. You know, the idea of development and working in these kind of access spaces is with better health, there's better wealth, and people can actually move up the development ladder. So we can't be creating systems that are designed to segregate or only deal with this set of problems and treat these ones as completely different. We can recognize that they're different, but ultimately want people to be in a common healthcare system that's integrated. So really, equity has to be inclusive. Equity has to include, all strata of income. It has to, work on aspects of solidarity, not just for, altruism, because again, that's not, where equity should be based. It's the fact that that's critical to sustainability. So equity and inclusion, we really think that that's kind of how you build these things sustainably. As a private sector company, sustainability is critical. Otherwise, why even enter the chat room?
Right.
And so in a post-pandemic world, or again, continuing pandemic, but we're changing norms. We think it's really important as you think about scaling innovations. More is more, but is more always better? Really focus and use health equity as a driving principle for how you create more. We don't want to just contribute to more for the sake of more, but more for more inclusion is going to be really important because ultimately it's going to contribute to the sustainability and really the equity, again, that not one size fits all, but everyone has an option. And I'm happy to speak more about that later and bring in examples of the contraceptive market, which is something I used to work in. But want to give a chance for my other panelists to come in.
But it's a really important point you make to say that we can't rely on political will coming from a sense of obligation. It has to come from a sense of mutual benefit. That if we leave the poorest in society untreated, we all suffer. So, and I know you.
Yeah. So, for example, in terms of adoption and trying out new ways of things. So, in our case, we have the B2C, wherein the patients are paying for the services.
Business to
business to consumers. Then we have the B2B, business to business, wherein we have the corporates are covering for the patients like the construction laborers who cannot pay for the services, as well as we have many geographies wherein the ability for the patients may not be there. And then we have the B2G, wherein the multilateral agencies are there.
Let me just stop you. I'll let you get on to the B2G.
Yeah.
But on the B2B, this is interesting. So
yes.
This is employers paying for their employees to have access to your care.
Absolutely.
But partly out of a sense of obligation, but partly out of a sense of wanting to keep the workforce focused and healthy and productive and compliant.
Absolutely. So for example, we work with construction laborers, we work with factories, industries, and before the pandemic, they may have only a small medical team in place, but during the pandemic, they have seen that that system simply does not work. Because it's not only about taking care of the employees, it's also taking care of the communities as well. Because earlier they thought that it's only good enough to take care of my employees and the contractual laborers, but during the pandemic and post-pandemic, what they have seen, that if the community is also not taken care of, their production is going to get hit. And that is where they have started thinking around that, and that is where organizations like iCure is coming in, wherein we have been able to adopt different pricing models based on the suits and the needs, but ultimately it's the patients who are getting the care. And one of the biggest example which we have seen in India in terms of the vaccine, same vaccine is being given free at a private, in a government facility, and the same vaccine is also the patients who are able to afford is paying the money because they simply don't want to wait in the line, is buying that. So the different innovations of adoption of the pricing model has also been done so that we are able to give the billions of vaccines in a record time.
But I interrupted you. So you've got this basically private sector model and then the B2G bit,
yes,
right?
Absolutely. That is how we have been able to look and work for. And even within that space also, what we have also seen that how you'd be able to, because now we are also seeing some of the biggest corporates with whom we are working, they also feel that, okay, it's not only about CSR or the grant money, it's also about how you would be able to make it sustainable over a period of time so that tomorrow when the grant stops, your service does not stop. So it's also about the patients, and we have seen patients who are demanding services. They're saying that, okay, we don't want free services wherein you are just giving some very basic stuffs, and we know that for buying additional medicines or buying additional services, I have to walk for 10, 20 kilometers, and nobody is giving me bus fare, nobody is giving me food, nobody is giving me accommodation. But here, if you are able to give all the services at my doorstep, I'm happy to pay you the money for that. So it's in a way wherein we have brought in innovation, adoption of the pricing models to make things easier, affordable, and accessible to those communities.
And Sue, I mean, you've got somewhat the same, right? You have a shared system between the private sector providers in South Africa, right?
Yes, we do.
But it's also accessible to, well,
Yeah, so prior to COVID, telemedicine wasn't regulated. So in South Africa, the Health Professions Council had to regulate it that doctors could do online consultations. And what this has allowed for us in the private sector is, because of the missing middle that we're servicing, documented and undocumented patients, it's allowed our nurse-led facilities to have access to doctors from the comfort of their consulting room. So doctors are able to do a consultation, a referral, a prescription without the patient leaving the facility. So we're trying to also, save costs to the patient, where you don't have to go and travel further to see a doctor. You can do that from the convenience of an Unjani clinic. And then on the state side, they've got a Vula app. So the Vula app is used by healthcare workers to refer patients. So it's a referral pathway to specialists in tertiary institutions. Also, nurses are able to share best practices, whether you're servicing a highly populated urban area or you're in that low-income area where, patients still need access to healthcare. So,
and I think the exciting bit of this potentially is that then you've got a patient who's with a nurse of yours in a clinic, yeah. and the nurse can be the arms and the eyes of a tertiary care specialist sitting in Cape Town or
Absolutely.
Johannesburg.
Yeah.
Wanjiro, I mean, you're making a particular focus, right, on reaching remote and difficult to reach areas of Kenya.
I just love this conversation a lot, because one of my best tagline is healthy people, healthy economies, and women in global health have now tagged it to healthy women, healthy economies. We have to realize that for our nation to be productive, for you to be comfortable, your neighbor has to be comfortable, right? And it didn't become any realer than in the last 2 years, right? So we have to realize that once we take care of the system and we take out the people in the vulnerable communities, then we are creating a system where eventually everyone will be able to take care of themselves, right? And we can focus on more critical issues like education, other issues that contribute to the economy of the country. So it's very important that for governments to support different partners who are coming in with different technological innovations, because they can see the bigger picture. And I have to applaud, some of the governments in Africa who are accepting leapfrogging, and for sure they're not rolling back. They are setting up regulation, as the gentleman said in the audience, and they are working with the partners. They're sitting down on the table and negotiating to set up regulation, and they are iterating as they go. They know they haven't figured everything out, but they're iterating as they go. So as I mentioned, a lot of partners have also come on board, because again, it cannot be done alone. There has to be a lot of collaboration. So it's the development partners, it's the public sector, it's private healthcare. And I have to commend also a lot of the private partners who are realizing that, especially in Africa, it can be business as usual. There are a lot of companies have had to re-strategize their business models to look at sustainable ways of delivering healthcare in Africa, because they cannot sell healthcare, as I would say, in the US, healthcare is a luxury completely. And again, they realize that this is an important market for them, because again, healthy people equals healthy economies. Thank you.
Absolutely. Tu, I'm going to come to you in just a second. Yes, I saw a hand over there, and then I'll come to you if I may too. If you were nodding off, that makes sure you woke up.
Yeah, thank you. I like this discussion around this equity and accessibility of health system and everything. We have a common saying in Ivory Coast where we say when you are poor, you die. But when you are rich, you passed away. It's to create that difference. But at the end of the day, we all go to the same ground. Yeah, it's the same sense. I would like us to push to open another door. The reason is medicine. It's not like if you need food, you farm a chicken, you farm tomatoes, you can have your soup and chicken. With medicine, it's more complex than this. So what I would like to encourage also is pushing our local communities to also look at the nature, the plants that can solve basic issues, and they have the experience, they have the knowledge. Our grandparents, they wouldn't die of headache because they know to find a way in the forest and solve their issues. So why not using technology to spread techniques from grandparents, which are proven, and spread it widely so that we can also support.
Although, I mean, it is, and you're right, there is a lot of old wisdom. But life expectancy in Africa, of course, if you look over the last 50 years, has soared dramatically. I mean, over the last 20 years, it's gone up 10 years, I think. But yeah, absolutely. Sorry, one more.
I have a question. Is that okay to ask?
It's yeah.
So, well, thank you. There's an amazing discussion, and I think what I'm actually really seeing is the future of how health systems are eventually going to evolve, because there are so many different models in which care is being provided. There's technology, there's your access to medicines initiative, the nurse ownership model, and the model that actually interfaces with multiple organizations to provide care. And in health systems where you have the state on one hand and you have non-state actors on the other, this is a great example of evolving partnerships that would eventually become the norm. So my question is that at some point, where do you all see yourself integrating as part of a continuum of care in country health systems? One of the biggest problems that countries are having with very vibrant, innovations is that a lot of them are fragmented. You work with nurses, you do primary healthcare, you do access to medicines. Each one of these are often different verticals. But at some point, you will need to integrate them or bundle them. How do you see that happening? So that's my question.
Well, interesting. So I'm going to come to all of you. Two, I might use that as the entry point, because in a sense, for a big multinational company, you might think that's the toughest to integrate into these kind of partnerships. Do you see a way to make it happen?
It is the toughest. I don't have the answer exactly for how to make it happen, but I can, speak a little bit about the principles that we're working off of to collaboratively write that playbook. Because let's be really clear, there is no playbook for that yet. The principles that we really, again, bring to this is the idea that access to medicine, certainly, the biggest disparities are in low-income populations, but we've got to take a holistic approach and really think through how do we use inclusion in multiple ways. Inclusion when how we do research, inclusion in how we do product launches, inclusion in really, the types of providers and clinics and facilities that we speak to. Being able to look at that collectively, use that data, and again, I don't take data for granted at all. That's part of, equity and inclusion. We've got to value this type of data for all populations so that truly we're building on something based on fact, not just assumptions about, this is what's happening in low income and high income, but collecting that data, using it in a holistic way, and that is the bedrock of how we'll enter into, writing a small part of this playbook. Ultimately, we believe that inclusive research, inclusive access to medicines approaches, inclusive facilities, that's what's going to lead to actual integration. To silo, any of those experiences and just say, this is happening over here and this is happening over there, those dots aren't going to connect together. Have we figured out how to, really enter the continuum of care and be able to serve all populations and do it well? No, but we are guided by these principles of equity at the heart of our research, at the heart of our commercial approaches, And yeah, really, again, I just want to reiterate, inclusion is a necessary ingredient for integration. And something I was saying before, it's not one size fits all, but one size for everyone. There have got to be choices in the market that serve the multiplicity of those needs. So I'll stop there.
And so it may be that there isn't a template. It may be actually we figure this out on a country-by-country, community basis.
Guided by principles, exactly, of equity, inclusion, and respect for our partners. It's not just a one-way street of only doing, what the public sector has been doing for years. It's about bringing that innovation, understanding that a mixed system is also a way for a healthy system.
So there's a need for principles, one, and there's a need, two, for this kind of exchange of ideas so we get to hear about these innovations and they can be copied. I'll come to each of you then, if I may, in turn, to talk about what it looks like from your side. So as a mixed public-private provider.
Yeah, I think that's very, very important, even though it might look tough at this point, but we cannot say that it's tough and we just sit by. For example, in India, something called as health system exchange is coming up. The idea is that we have very fragmented insurance, in India. And even though there is a mandate from the central government that we need to have an equitable, platform wherein everybody would be able to come by, but being a federal structure in place, it may not be possible that each state government is listening to the central government. So here, the whole plan is that how each of the state government would be able to play their own policies in a way, but also live in the larger ecosystem, wherein, let's say, if a patient have a particular card, and if they simply walk into a particular hospital, that hospital may not be part of the insurance which the cardholder is, but they are able to eventually be part of the larger ecosystem. So in a way, we are trying to bring in such flexibility and openness wherein we have certain policies, priorities of these individual or these state level bodies, but at the same time, they are as part of the larger, central government umbrella. So we have to think of such innovations so that everybody is able to play within their own rules, but at the same time, everybody is able to contribute to the larger means.
And so government is learning from
Yes.
everybody, seeing patterns,
Yes.
making
So there is a
connections.
certain bit of flexibility which is there, but then there is certain framework within which they are playing on that flexibility.
By the way, for people who don't know India, Sujay said earlier Nagaland. So Nagaland is, I venture to say, the most remote part of India, right?
Yes, absolutely.
The
Yeah.
most remote, the most economically challenged, probably, or among the
Yeah,
most
right.
economically challenged. And so we should just highlight how remarkable that achievement is. Wanjiru, I'll come to you, and then Sue, I'll come to you after that, if I may. So you work for international NGO, for Kenyan operation of an international NGO. How does it look from your side?
I would like to say that it's a lot of work in progress, right? But some things have been seen to work, right? I would like to give a good example of malaria medicine, Coartem, done by Novartis, big pharma, I think #2 in the world. And what's very interesting and remarkable to say is that you can find Coartem in the most remotest place of Kenya, if I should say so, because there is a market for public and there's a market for private. And we as NGOs or as advisory consulting firms, we advise big pharma, how do we access the public health market? But at the same time, it's important for them to maintain their sustainability goals because again, if they don't make money, they won't go back to the lab and discover more drugs. So we have to create a balance for them. Another example is like the HPV vaccine. We have all girls above 11 years old in Kenya can access the HPV vaccine, whether it's in the public facility, and if you can afford it, you can get it from the private facility. HPV vaccine is currently being manufactured by MSD, Merck in the US. That is big pharma, and yet the product is able to reach to the last mile in the most remotest part of Kenya or any other African country for that matter. So I guess there has been successes, but there's still so much more to be done. And the more governments, adopt technology end to end, because again, the challenge is technology reaches up to a certain place, and then that's where NGOs like ours now take it to the last mile.
And to your point that it doesn't become fragmented, it doesn't become the HPV system, it
Correct.
doesn't become the malaria system.
Correct.
Sue, private, a really innovative but private service provider, how does it look to you? How do these partnerships evolve? And of course, South Africa adopting a national health insurance system.
Yeah, so national health insurance coming. It will impact how we operate in the private sector, but it's still a gray area. You know, nurse-led primary healthcare in the private sector was uncharted waters. We've made some great strides in the last 10 years. And like Tu said, we don't know how to link ourselves to the private sector, to big pharma, because we needed to have a digital footprint. And that digital system that we've designed now gives our patients a record. It allows us as headquarters to be able to look at the social impact we're having and take that data to the private sector and say, support us. You know, we will continue to ask for support from government, but most importantly is the private sector are able to recognize what the nurses are doing in terms of chronic management, disease management in the communities. And that's where the patients are.
And as Tu said, that's how the exchange works, right? I mean, there's a learning process that a company like Gilead has because you have the data and you have access. It's an exchange, yeah. Listen, I've learned a great deal. It's been a fascinating discussion. Thank you all for staying. I know it has been a really long day. Thank the panelists for me, if you would.